problem on the other side is there is no gatekeeper in the AI industry today. There are some laws, there are some guidelines. I think in AI right now, we don't see that happening. Sometimes you don't do anything, but you do no harm. That itself gives you...
Someone who started his career looking for a leadership role over a period of time, should there be more preparation that should go? Welcome to the Healthcare Tribe podcast. I'm Amit Gandhi. We started the Healthcare Tribe podcast to take through the journeys of leaders in healthcare. And today we have Dr. Nanivadekar, popularly known as Nani in his circles. And we will go to Nani right away. Today we really want to have some conversation around your journey, your personal journey in terms of radiology, as well as your career journey, your life journey in general, your leadership lessons that you have taken. Few things that I want really for our listeners to take away, at least, apart from many other insights. One is what if they are today looking at radiology as a career, right? What they should be looking at, what they should expect. And of course, the AI is a big word nowadays, and what its implications in radiology are. So apart from your personal journey, these are some of the few areas we'll cover as we talk about it. But to start with, let's start where it began in terms of what interested you to make a decision to get into medicine, or what were your early years in general, and if you can tell just a little bit about that.
Well, thanks, Amit. Thanks for having me here. So it's going to be a very cliche answer, I never wanted to be a doctor, and I wanted to do something else before, and you eventually get pushed because of these circumstances. So whatever is your family requirements at that point of time. So I come from an army background, so the usual norm is to follow the footsteps of your father, and I wanted to join the NDA and maybe to go to AFMC, and even my younger brother almost got through to get into AFMC. We just thought we will get into that glamour of the army life. Unfortunately, that didn't happen. Not that there are different reasons for it, but that thought that maybe we are a little bright to kind of pursue something more challenging. Not that army is not, with all respect. Definitely he thought, I could be somebody more.
And that was your father?
My father kind of said, you could look at something more professional. He was an engineer himself, and he was in the Army Corps of Engineering. So I chose, my maths was not great, so I decided to pursue life sciences, which I think is, for me, was very exciting. And I chose medicine, and I kind of got there eventually, not that first shot. We didn't have NEET or those kind of exams in those days, so it was only on the...
And you were brought up in Pune?
Well, I kind of traveled pan-India. Like I said, being army family,
you had to.
I had multiple... My dad got posted in many places, so I kept moving around, made a lot of friends, Kendra Vidyalayas and everything. But majority of the schooling in Pune, almost 3 to 4 schools in Pune, depending upon time and when my father was posted here. Medicine happened after a gap of 1 year in which I had a 6 months journey into pharmacy in Bombay College of Pharmacy, Kalina, and then made friends there. And there was another 6 months in which I went to pursue dentistry, and finally my name came up to medicine.
Wow. So it was quite a journey.
Yeah. But it was not a journey of desperation or I knew I would get it. It was just time of the list moving up. And I think that's what kind of gave me 1 year of being in college, and knowing that you're going to finally go there and not worrying about I might have to give another exam.
I think some of it is little, little contemporary, in the sense that nowadays, a lot of kids actually explore. That's my perception, I might be wrong. But in our time in general, right, it was like, okay, you give the exam, you go in, everything was really much more pre-planned for most. I can't say for all, but for most. Nowadays, I see kids really exploring, giving a chance, figuring out what they want to. My son, for example, has taken a gap year after 12 to figure out and get into a better college in legal, and he wants to do law and stuff like that, right? But you did that kind of a long time back. How would you reflect on
So
that
I
year?
would say that was not a break by choice. I would have loved to get into medicine earlier, 1 year, maybe I would have come out earlier and I would have a different set of contemporaries and peers, and maybe I would be, it would have been a different direction. But at the same, maybe I would have passed out from Bombay, and that would have been a totally different journey.
Right.
But I ended up somewhere else. But that's fine. So now people take it as a choice, and I'm very glad that both my children, my daughter and my son, both took gap years to basically understand whether they really want to do this but not for a better college, but for pursuing a better career, a choice or a line. Not about that in the same branch, but a better college. I think that's unfair. I think you should be very clear about that. You cannot jump. For example, take medicine and then drop out because you want a better college, because it kind of creates a lot of issues. But taking medicine and leaving it after 6 months, saying that you want to do law, that also is not fair. So I think yes, but each one to his own.
Right.
I think in our family we had it good, so it worked out very well for us. So I'm happy.
And you landed up doing medicine.
Yeah, and I ended up doing M.B.B.S, and then that's where the problem starts after M.B.B.S.
Okay.
I think most of my peers and my friends would agree that it's becoming an M.B.B.S doctor is not so difficult as it was. After M.B.B.S, what do you do, and what's your choice of post-graduation? Depends on many factors. And I think for me, I was very happy. I didn't have parental pressure. They were not doctors. There was nobody in my family who was a doctor in the immediate family. So nobody could guide or misguide me or push me. Plus, we didn't have so much of choices. We just had merit, and that decided whether you get into the top 5 or top 3. And my time, orthopedics, pediatrics were two very high sought after branches, and radiology was an unknown kind of thing. It was just introduced, at least in the state of Maharashtra, in medical colleges. Bombay was popular, and I was very fortunate. I had maybe a liking for the subject. In my undergrad days, we didn't have much of radiology exposure, but I used to find it fascinating, and I used to love technology and tech. So for me, I thought this is something much more easy for me to pursue as a career, as a hobby, and make it like passion. It kind of worked out well in the end, and I guess that was how it got crafted.
Earlier in our conversation, you once mentioned that you wanted to do radio news.
So I'll tell you.
So from radio news to radiology, how did that happen?
A couple of things is I wanted to, as you grow up as a child, everyone dreams of being something or the other. Like now, if I have to go back and think if I would have pursued that career, where would I have been? So radio announcer, basically watching news in those era. I wanted to be a radio announcer. I used to hear a lot of news, to hear on the radio, BBC, and because American Broadcasting Corporation, and used to hear those crisp news and the dialects and the kind of way they used to deliver the message to the whole world. I used to wonder that how much of power that voice commands when people listen. Even commentaries.
Of course.
They used to paint the whole world for you. With your eyes closed, you can imagine. So I can imagine that was like for me, the power of kind of reaching out to so many people, I guess. But it didn't happen. But yes, eventually I went on and held the mic in my hand to MC at gatherings in college, and getting stage fright, getting booed by seniors. That was like one of the times when I had stage fright. And then eventually maturing enough to understand how do you hold the audience interest, and then doing quiz competitions, and then gradually getting the confidence of, hosting workshops and speaking on forums and moderating. So I guess that was something which was maybe one of my inbred.
The fact that you've worked in multiple places in terms of cities, as well as cultures, and now you're in Tokyo and all of that. Do you think this whole military, I was thinking, right? And this whole military background, as well as this kind of varied interest, really helped you do such transitions?
So
How would you think about
I
it?
would I would look at it in a way. Yes, definitely it does help, because being an army brat, you usually are used to moving places, and
Yeah.
so you're smart at packing. Your father
Right.
teaches you how to pack efficiently and how to move quick and traveling light and easy, how to make friends. And then I was, I think, always a people person. I mean, if now, of course, yes, the place I live is something which is not as friendly in this terms of making friends, unlike India. So yes, I think people connect was something which came to me very easy, and I can blend and I can adapt, and continuously make friends and associate with people. And so yes, it does help. So moving cities, moving jobs, moving cities, moving careers. I think all three, if you roll it up in one bag, it has been successful for the simple reason, because I could relate to the people there, be it Kerala, be it Singapore, be it now in Japan, or be it in India itself. And I think that is advantage which growing up in the household kind of helped me to.
Yeah, no, absolutely. So, going to career transitions, and I love to talk more about that, because that's kind of a lot of people do that a lot often, and it really helps to kind of get lessons on how to do it effectively. But before going to those transitions, I would love to really get your view on how your radiology career evolved, and what are some of those things that you learned around in your days of radiology practice in the initial days, and how did those go? What are some of the things that you can take away from those?
So I think I had it very easy in my whole career life. I never had to kind of feel the struggle. I think opportunities knocked, and when they knocked, I was at the right time there to open the door. So I would not say I had a struggle. I was fortunate, I would say. The stars were kind.
But you immediately started liking radiology as a field?
Yeah, definitely. The day I joined radiology, I think the best thing about doing radiology in a government medical college is it's a self-learning journey.
Yeah.
You have the very basic things, and I had the best professors, the best seniors. And it was like you're pushed into it and you learn it. And I think I call it not a profession, I call it art. I think the art of radiology is something where you have to be an artist with your eye, with your mind, and the ability to express that in the way people understand it, in a simple way called reports. So the power of language has to be there. Of course, the power of vision to see and to pick up the nuances. And I think I was very fortunate. I learned from the best.
Wow, that's interesting. Radiology is an art. Tell us a little more, like elaborate with an example how you say that.
So the thing is, the art means you can tailor or rather customize every radiological procedure to suit an individual. You don't have to follow the same protocol for everyone, and I think that's the best. In the sense, I'm sure surgeons also are doing those kind of techniques when they are operating. So let's say if I have to do a study on you, which could be a barium meal, or for others in the room, I would tailor it to your clinical needs, to your body, to your size, to your weight, to your emergent or elective needs. And that's where the art comes in, that you become an artist. You don't do the same procedure for everybody in the same manner written in the book or in a protocol form. I think that's where the first level of art comes. Second is when we convey the findings, that also is an art, as an artist, because you can convey normal findings in many ways. And you can also make normal findings confusing. And you can make a complex report look difficult to interpret.
Would you say that this is really a different view? So would you say the difference between a average radiologist and a good radiologist is ultimately this art?
I think I would not call anybody average or good. I think radiology is, once you do your MD, I think you have it in you to pick and choose how you want to scale yourself in practice. It's not you being.
But don't you think there will be various degrees of radiologists?
No, I think learning is something which everybody learns the same. Nobody teaches you less or nobody teaches you more. It's about you're like a sponge when you're doing your MD. You absorb.
No, not while learning. I'm saying as an outcome.
So
finally,
as an outcome is when you practice. That's what I'm saying. When you practice it, it depends on how much effort you put, how much you press the accelerator to leverage your practice and make sure that what you do helps the outcome. I mean, I think all the radiologists worldwide will put 100%. I mean, every doctor would put 100% in that. They would not cut corners on practicing that art. Yeah, they might get a little bored at sometimes. There could be monotony. That's the reason you have career transition changes. You move from conventional to ultrasound to Doppler to CT to cross-section. Then you go into the organ-based imaging, or you go into modality-based imaging, or you practice niche like super specialty, maybe cardiovascular or intervention. So like you say, you have seen radiology as a field.
Yeah.
You look at the neurointervention radiologists, when they do embolization or aneurysm coiling, it's like a fine art.
Oh, it is.
It is. It's something you talk about intervention cardiologists for that matter, or anybody. You talk about any radiologist doing any procedure. It could be something simple like a barium swallow to something complex like an embolization. It's an art. And even the report writing is an art. So I think I call radiologist, I've been very fortunate. I think I'm an artist.
Nice. No, that's nice. That's a very, very nice way of looking at it, and probably that helps. Now, so that's the point now. So I'll probably jump into one exciting area which I initially planned to actually talk a little later, but because you said this, the report making nowadays, right? The report making, there's a lot of things happening from a Gen AI perspective. That reports are getting generated. Will AI be able to be an artist to do that, or do you think?
So Amit, again, I'll come to it. When you say report making, that's like, I would not use the word. I think a radiology doesn't make a report. A radiologist constructs a report. Fair enough. He constructs a report based on the person. The thing is, I think there's a saying in medicine. It's like we don't treat reports or we don't treat laboratory findings. We treat the patient, and that's something which I take very seriously. And I've been telling all my colleagues, my juniors, and my team as to every person who comes into the door to get a service is not a number or a so-called or code, or a QR code. He has a symptom, he has a need, and we need to make sure that we give him that outcome which will basically help him get better, whatever it is. So I think constructing the report, and that's where I don't want to talk about generative AI or AI in making reports. I think that's a totally different discussion, and I'm not that, I would say, expert to talk about it. But what radiologist, when he constructs a report, he looks at the patient, he looks at why is he being referred, what's his symptoms, are they matching? What is the doctor who has sent him seeking exactly this? And which is the appropriate test which I'm going to do? Is it correct or not? And do I need to make any changes in the way I do the test? It could be in the amount of contrast media, the choice of contrast media, the kind of system, and the kind of radiation or non-radiation, whatever I'm going to do for him. And at the same time, how fast my report is going to change his life. If I'm going to do, no, I have a 24 hours turnaround time for this and I can do it tomorrow. No, the person needs a report which has to be early. So I think these are the factors you need to take into consideration when you make or construct that report, which is not right now addressed by this so-called.
You don't see that
they are not
currently being addressed.
They are looking at an image and they're doing a diagnosis. But I think behind that image, it could be an X-ray chest which you have. There are so many stories which only a radiologist, when he talks to the patient or to the doctor, or he's told by his colleagues, I think that brings a lot of human element into the whole context. And so that's what.
Oh, that's interesting. So today, for example, someone is just got an admission to a radiology, M.D. Radiology, okay? So they want to, or just wanting to start a practice post their M.D. Radiology. They want to start their radiology practice, want to become a very good radiologist. What are these factors? So one, of course, I got is the artist element and the ability to look at multi-parameters. What are the other factors that they should really be working on? In your opinion, I'm not saying you would, I mean, you will have your
So
view?
if I have to give my 2 bits to a budding wannabe radiologist,
Yeah.
I would kind of tell him, just spend a week working with a radiologist in a hospital or in his practice and try to understand what is it that he really does that makes him so hot favorite for you to choose that profession. So there could be challenges within their own mind about family practice of radiology, or maybe it's something which is very financially rewarding, or it doesn't have 24/7 kind of it has a better work-life balance. People have this perception. So I think what they need to understand is what they seek from radiology is how they are going to use this branch of medicine to touch every sphere of healthcare. In the sense, it could be neonatology, newborn baby, to fetal, all the way to oncology, to neurology like dementia. Radiology touches almost every facet of healthcare, including dermatology now.
Yeah.
So it's a huge syllabus. It's a huge curriculum. It's constantly evolving. I think it's evolving more than any other branch of medicine. That's my personal opinion. And it's very tech dependent.
Exactly.
So you have to keep adapting, because it's not something like I would say any other branch of medicine which kind of stays stable for years together before something new comes in or new guidelines come in. I think the AI also is something which we have to look at. It's behind our shoulder. We got to keep looking back. We also have to keep industry in our thoughts every time when they come to us, not just to sell, but to how we can partner and make them better. We also have to look at what are the changes which are happening in the other fields. It could be genetics, it could be translation medicine, it could be something simple like a home care, in which radiology plays a big part, and how that is changing and how I have practice. So I think for the radiologists, there's a huge thing. For a new radiologist, huge things to
Would you say that radiology, and as you say, right, I mean, I get a sense that, and now if I reflect back, I kind of tend to agree as well, prematurely probably, but still, do you think radiology is more dynamic as a field vis-a-vis many other healthcare places in terms of the factors that get impacted for radiology?
So I wouldn't say no to this, but at the same time, I feel there are a lot of other branches of medicine which are equally dynamic.
Right.
So dynamic, in the sense you can kind of define it in 2-3 ways. One is dynamic in the sense it's matter of life and death. Maybe like emergency medicine, you got to really make sure that he doesn't die. Dynamic could be that you're 24/7 reading or doing something for the people. That is also different dynamics.
Yeah, different.
The third thing is that industry is moving so fast that you keep reading, and
that's what I meant. Dynamic from a learning
perspective. No, you can choose to be pacing yourself depending upon what facet of radiology you practice. Somebody like me, I've always changed my radiology gears for the first 18 years in which I was in one institute. So in 18 years, I moved 5 modalities. I started with conventional X-ray because that's what I learned in my college. I jumped directly into MR, then I jumped into ultrasound, then I jumped into CT, and then I jumped into intervention, and then jumped into nuclear medicine, PET CT. So I worked in those 6 facets over 18 years, in between growing from a young junior so-called radiologist, observer radiologist, to a radiologist, and moving up the career path and getting kind of fast track to lead the department at an age where I was just trying to understand how business and practice works. So I transitioned in that fast way, and I realized it was not boredom or monotony, but it was a need, because there was nobody else and there were very few colleagues, and they had their other priorities. So I had to kind of be a radiologist to offer that solution to the institute that wanted it. So it was by many, I would say, factors. But again, coming to your point as to pacing, like I told you, you can pace it. You can choose to stick to what you're doing and say somebody else will do it or get somebody else. Or you can say, all right, I would do it.
And still you can make a good career out of it, right? I mean,
So-
for a budding, so if they have a different needs of pacing and specialize within it, do you feel that there is a scope for that enough?
So I'll tell you, I have a different opinion out here. I think making a career and getting into this kind of, I would say, path, there are two different factors. Making a career is you have your goal set. That I will get into this hospital or I'll work in this institute, I will learn this from this gentleman, I will become the best, and then I will move to the next. So there are milestones which you put on your whiteboard or whatever it is. That's making a career. But I think it doesn't necessarily mean that you will learn or you will be good in that. Suppose, to give you an example, if you are one of the best musculoskeletal or OBGY ultrasound specialist, and I say, okay, I will work with Amit for 2 years, I'll get all the nuances and the fine, I'll be his eklavya and I'll get everything, and then I will move to the next person and I'll learn. It is not as simple. It is not that you are giving an exam, passing and moving on to the next stage. I think radiology is something which has to be learned. You need the right kind of mentor, you need the right environment, the right technology, you need the right kind of patient flow. Can you imagine the students who learned radiology during the pandemic time? They didn't have variety that we had. I mean, I started my radiology career even before I passed my MD. So I had not set any milestones. And I guess now youngsters, yes, they do and they should. And I started setting milestones for my career and path also. So telling you, what I wanted to tell you is defining a career and making a note of it is fine. But to get that to happen, it depends on kind of patient that you are seeing, the kind of institute that you're working, and the kind of mentors that you have. And I think radiology is something you have to be mentored. Like
I get a sense from you, and that's where I might be started seeing a difference between. So you have done the corporate career as well, right? And in corporate career, mentors are useful everywhere. I mean, in life, everywhere. But I get a sense that probably in a field like radiology, the role of a mentor is even bigger than, say, in corporate career. Would you say that? I mean,
I would call it larger.
Larger, yeah. That's what.
Because a mentor in
more important
than a mentor. I have been mentored by the best. I have been a mentor to quite a few, and I feel very proud about it. The fact that you can talk not just about the subject of radiology, but you talk about the whole looking at the patient or your organization or your department in a very holistic kind of way, in the sense what is good, on being conscious of the cost, being conscious of safety, being conscious about having empathy as the first emotion in the practice. A mentor teaches you about values.
You will be comfortable to tell who were your mentors? Like a couple of them.
Okay, my best mentor. I have a couple of mentors here. So I think one of my biggest mentor has been Dr. N.G. Deshmukh. He was my teacher, and I think he was one of the finest radiologists I could have worked under. I mean, great man. And he taught me. He held his hand and taught me radiology, and how to read, how to report, and how to take care of patients. And I think that's one name who really kind of mentored me. The people I worked in, the first organization I had, Sanjay Vaid, he's been a great mentor. There have been mentors who have been younger than me, and who have mentored me, like Ashish Atre is a great mentor.
Oh, I know Dr. Atre very well.
That is there. And of course, as you move different paths, you find mentors in the corporate career. I had the pleasure of working with somebody like Dr. K.B. Grant. He was my first boss to be on clinic. He gave me the first job. That interview was not even a job interview. I was just waiting outside his cabin. He opened the door, took me inside. I said, I'm a radiologist and I want the job. So he says, you can start working when? I said, tomorrow. He said, no, why don't you start working today? So that was
Wow.
the time I started working on that day. So
you also went on to head, the entire radiology department. So that's kind of a little transition from the kind of radiologist work to a little bit of leadership work overall.
Yeah.
What would be some of those things that changed,
so that
and
was,
you had to like really look for and learn?
yeah. So that was something which happened by, I would say, serendipity. Thing is, we had a situation in our department, and a couple of seniors left, and there was nobody there. So I was summoned by Dr. Grant and the medical director, and they say, we have only you and your colleague left, and are you able to handle the department? I said, yeah, I can handle the department. So he said, okay. Kind of gave the mantle over to me, and I worked just 5 years into practice, and I kind of in a year's time.
Oh, it was that young, is it? Oh, that I didn't realize. So just in 5 years in practice, you got to head the entire department.
Something like 1998.
Wow.
I joined the hospital I finished my MD in 93 December, and I think 98 I became the so-called.
So it came by not really design. It just happened. So yes.
Then you had to take
and to really have to
which
respond.
were as a full-timer, as the only person leading the department, right from signing inventory to decisions on deciding on giving discounts and concessions to patient, having the empowerment to make.
Yeah, and you did that for a while, right?
So I think that was a long journey.
Yeah.
And I was also fortunate that gave me the ability to bring in different technologies, to interact with industry, to learn, I think, the fine aspects of ethics, regulatory, compliance, procurement, negotiating, the art of negotiating, the basically
negotiating with people like us,
and learning. I learned a lot from industry. I think industry teaches you a lot, and that's the reason.
So is the leadership role has many different capabilities that, say, budding again a radiologist who is in, or is just someone who started his career looking for a leadership role over a period of time, should there be more preparation that should go from building newer capabilities, or you think it's kind of directly evolves?
So I think it depends on. So I'll tell you. I think leadership is something you aspire to be a leader. At the same time, it also depends on your leader, whether he looks at you in that way that you could be somebody, not just a second in line, or it could lead a separate vertical, or you can hand over certain functions. I think that's how we create leaders within the organization. So the mandate in all the organization always is to create a second line, third line. I think, if you consider leadership styles, then I think if I have to label mine, I would choose 3 styles which I work. The first one, of course, is laissez-faire, let it work, because I don't have to teach competent radiologists how to do their work. But what you can teach them is, okay, I need you to start looking at audit as an opportunity, or quality, or maybe I want you to look at cost cutting, cost saving, and try to use, or somebody could manage safety. And that's what also changes them as leaders. Because being a great radiologist doesn't mean you're a great leader. You need to have the other nuances of things. The other thing I would say is I look at transformational leadership as my style, where I would like to motivate and, I have pep talks and meetings and talk about things and understanding their work-life balance and trying to get them to go push them beyond the boundaries. And the third type would be, of course, situational. Because there are certain situations in which I know I'm not a great leader and have to rely on somebody else to do certain things. So it could be crisis, or it could be sometimes difficult situations where I'm not able to trust myself to solve that problem. Then I have to bring in somebody. So, you have to. So it's not just one style of leadership. And I think that's where I think when I teach students, or when I used to teach students, and when I used to take them for mentoring, I used to tell them, you will learn radiology. if you are 3 years in any department, you will learn radiology. There's something which will rub off on you as a part of your journey with us. But what you will not learn is these other skills which I was talking about. That is only by observing, talking, sharing, venting, failing, meeting different kind of people.
And then you, from heading a radiology department, you moved to taking roles which were even beyond radiology, but within healthcare and in corporate structures. What was that transition like? Is that a lot of difference in the way, and what if someone really aspires to do that, what should they really look at?
So that, to answer your question, that was something which is, I think, troubles me a lot. My first transition. I was in one hospital for 18 years. And when you're 18 years, there is a little bit of, so people talk about burnout. I don't call it burnout. I think I call it monotony. When you feel you are told by friends like you, industry, that you can do more. World is bigger than this. You feel and you see, and you travel and you go to conferences and you get a lot of, I would say, opportunities to understand, and you understand, oh, this is something in radiology people are doing outside, and maybe I should also look at these things. There's something which I can carve more out of that big cake for myself too. And I think RSNA has leadership sessions.
Yes.
ECR has leadership sessions, and going to these conferences gives you a lot of insight, not just clinical. I would love to attend those admin and leadership sessions.
We in G used to have this Crotonvilla sessions for even our customers in radiologists, because that just adds a perspective and stuff like that.
I have Crotonville in Singapore.
Oh, you've done that.
Do those courses. And so, like I said, that 2012 was a very crux year for us as a family, and I think that's where I took the plunge, and I took a sabbatical for 6 months. I didn't work because I had to get out of this monotonous path. And when I joined multinational, I moved out of the country. Those 2.5, 3 years were not really that rewarding for me in that MNC, in the sense I could not pursue those kind of dreams which I thought I would. I was thinking and seeing, and I think it took a hit on my professional life too, as well as a personal life, because we had to move countries. It was not good for the family. But coming back into the driver's seat as a radiologist, with a little bit of exposure from MNC, understanding what is it now, and then following it up with management studies, it kind of changed. So that 2015 onward journey was totally different.
But was there any, would you say, reflect back and say there was any useful learning from in the MNC? No. That's nice.
I think there was no, that time there was no useful learning. Absolutely no. It was just, I think, the chance to stay outside India and explore overseas world, and travel a little bit, meet different people. And I did do many useful things in that time. But I think people should be very wary when they take a transition career break. They should be very careful. They should think it out. But then,
what are the top considerations they should have?
First of all, they need to consider how much time you want to spend away from your core profession.
Right.
3 years, 2 years, 1 year. 1 year you don't really learn anything, and you don't even judge your capability in 1 year anyway. The second thing is you need to understand it's just not money that matters. It matters a lot about satisfaction. As a radiologist, you always come home and you feel, oh, I did great today, you sleep well, you do great diagnosis, you do heroic procedures. Sometimes you don't do anything, but you do no harm. That itself gives you very good night's sleep. It keeps your conscience clear, and I think that's very important. So you're basically not wasting that journey of radiology that you're practicing.
Right.
You're not sitting on a desk and making PowerPoints for some marketing presentation. You're being a little bit more than that as a radiologist. So you should understand your role and your KPIs and your expectations very clearly, because The industry definitely needs people, yes, but are you the right person? So I think it's very important to kind of pause, take a break, come back. Talks a lot about your mental health also, because sometimes this was in 2012. I think mental health in workplace was not considered a situation that time. Like today, it is talked about.
Yeah.
HRs talk about it today. That time, it was not there. You just relying on, you're blaming a lot of other things like, too much of work, less money, and, you're finding excuses to basically get out of that.
Get out of the session. Yeah.
So I think people should
Can be
know,
frustrating if
are
you
you going
feel
to
not
be,
utilized.
how long are you going to be away? It's like people say, I'm taking a break from acting, I'm taking a break from this. It's not like that. For professionals, I think all of us, it will be too cliche to say that.
It's not. So, so in a way, as a radiologist or someone like a clinical profession, everyone has to think hard before they do transitions, but have to think probably even more harder when they do transitions which are different in multiple parameters, right? So in a way, you changed many things, right? You've changed the country, role, industry.
Yeah.
3 things at one go, which is huge.
Yeah, with family, not
and
alone.
with family,
family.
which is
So
like
so basically
phenomenal change.
So you're
right?
burdening your decision on somebody else.
Yeah.
That's a big cross to carry.
Yeah.
So again, I come back to the first question. If you're taking a break from your path, you need to know, are you going to come back?
Think
If
ahead,
not,
kind of.
are you going to love that new path and you want to continue on that journey and not want to come back? So if you're a clinical person and you're taking a break, so you're going to in a university to teach, where you're not doing clinical work, but you're doing teaching or you're doing research. But if you're going to come back again, so you always need to have a back door open.
Yeah.
Till the time you realize I'm going to shut this and I'm going to move on. Like I'm advanced in some different business line.
Right.
Or you need to understand, I think choice which I made was I was a clinician. I was a radiologist. I moved into a company which was into sales and marketing and device selling. I didn't have any metrics or any qualification to do selling, marketing, sales, business development, strategy. I didn't even have a management degree or anything. I didn't understand Excel, finance at that point of time. So I only knew clinical, and how the company uses a clinician like me is absolutely something which that company also has.
Yeah, absolutely.
But today, if I hire radiology, not many radiologists come and ask me, Avinash, you would like to work. There are roles. They have people in the organization of medical device companies, and there are many consultants. There are advisors, medical advisory board. You have KOL connects. There are many ways to contribute.
Absolutely.
People like to contribute full time, or people like to contribute occasionally, or erratically, or episodically, as and when the need comes. So I think it's a good, I would say, journey. I have no regrets, but at the same time, we need, like I said, we need to have a plan B.
No, that's fantastic. I think this is very useful for people who are looking at transitions and also what to look at, consider, because you have so many ingredients in it already that people can find this very useful, I'm sure. Now, I'll take a segue to really back to radiology and say an AI. And that has been, of course, a big topic. In my view, of course, radiology has progressed in AI a lot, or AI has progressed in radiology a little more than many other places, primarily because of 2 things, but that's my view. We'd love to know your view as well. One is pattern recognition in general is a low-hanging fruit for AI from the way the technology works, AI technology works. And second, radiologists has been more tech-savvy from in its history. So the data collection has been much more because of the PACS development and all of that. And so data has been the raw material for AI, right? And hence, again, that has been a reason why AI. So 75% of AI in the world, FDA-approved AI, is radiology, for example, right? But from a clinician's view, this is very much an industry view or looking at AI's penetration in radiology. But from a clinician's view, how much is it helping? How do you see AI really penetrating radiology, how much it will enable radiologists. Those questions that many radiologists and clinicians have on their mind. How do I make use of AI? And are there some really good examples where it has done some significant job for a radiologist, considering the challenges? Anything on those lines?
Yes, I think Amit, the multiple questions, and I cannot put one or two answers to this. I'll give you a couple of my, I would say, concerns when it comes to radiology AI. So I feel the first issue is, yes, AI is needed, definitely in healthcare. The fastest adoption and usability would be in radiology, definitely. In radiology, whether it is going to be in detection and diagnosis, that's pattern recognition, workflow optimization and improving the efficiency, or the third thing would be in aiding accuracy or defining treatment pathways. I think forget the first one, I would put it right in my last number. Optimizing workflow efficiency and maybe to an extent of triaging normal from abnormal would be my first low-hanging fruit, already used, adopted, tested, and I think ready to go. Second would be on taking human in the loop, calling it not artificial intelligence, but I would give it something like assistive or augmented intelligence, which basically keeps a human element in the loop to kind of help the patient, would enhance diagnostic capabilities. But to use it for the diagnosis and to detect would be something still a long way to go. And the reason for that is, again, two-pronged. This is maybe globally. First is the messaging that radiology AI works, or radiology AI is useful, or radiology AI is something which you need in your hospital. The message has been kind of fractured in the sense it's being heard by different stakeholders in a very different way. So there are three main stakeholders today in radiology AI. One is the radiologist, per se. Second is the person who is the so-called CIO, CTO, or the so-called technical person who authorizes or embeds AI in the healthcare system of a hospital or a practice. And the third one would be the person who's right at the top of the decision-making tree. It could be a owner, CEO, a promoter, or the radiologist who's the...
And to an extent, even the clinician, right? The one that you would send the report to as well.
The clinician would not come into the decision-making of adoption. So these three people. So I think for them, they are not hearing the same message. Messages are going in different ways. First, that has to be kind of conveyed in the right manner. Then once the three are together, that we are going to use AI for this purpose, and we are all collectively endorsing that this is going to be our path, and this is the way, the message, when it gets stronger, then the detection and diagnosis becomes easier to come. But I think that's the message. The problem on the other side is there is no gatekeeper in the AI industry today. I think if you take the similarity of how MasterCard and Visa and diners, they work on the gateways of financial transaction using the cards. There are some rules, there are some laws, there are some guidelines. I think in AI right now, we don't see that happening. People talk, say we have, but I don't see any policeman or that matter of fact, anybody with authority to give a rap on the knuckles, except for a US FDA approving a product, but where to use it, how to use it, which scenario, that is not there. That brings in a lot of confusion. And for me, the biggest concern about adoption of AI is the bias on the data. Where the data is collected, what is the bias in the labeling, what is the bias in the cohort of the patient population from which the data is being used. It could be chest x-ray from South Africa, and you're using that algorithm for United States, or the disease pattern, the prevalence. Is it the real world evidence that you're carrying? What is the authenticity of that data bias. That is the reason there is mistrust, and I think it will take a long time for it to really mature. So I would be very cautious on adoption.
So if I would love to summarize some of these points, okay, so that the listeners also. So one, and let me understand. Correct me if I'm wrong, right? So what I hear from you is, one is data bias, and how strong that quality of AI, if I can say, is. That's like one. Trust on that is the first barrier. Then you're also saying somewhere institutional clarity on the purpose of AI is quite fragmented and fractured. Absolutely. And in a way that needs to be corrected in the first place, right? Then you mentioned in terms of, even at a very fundamental level, what is the purpose of this? And you said triaging, it might be useful, but then the question is it useful enough yet? Are you getting that much of productivity gain? And I was not very clear about that, but probably you can clarify more. And then you said regulator. Lack of regulation can really be not actually help adoption, but stop adoption because of this. Is that right? These are the four things you
I think mentioned. And number 2, the 3 people who are it could be 4, it could be 5. The stakeholders who are the guardians. So, for example, as a hospital, you decide you want to go for insurance. Or you're not going to go for insurance. You want to go for the Ayushman Bharat. There's a decision-making person. Right? They all have to have a same yes.
In a way, there has to be a strategy for AI in the first place as an organization. Which we all agree, right? I mean,
and where to use it.
Where to use it.
So coming to that, the third point that you talked about is triaging. That could be the first case scenario. I'm saying more than triaging, there are so many things which you need to basically put into that. So where to use AI, that choice has to be by the clinical teams,
right?
Not by the tech teams. That's my perspective.
Right? Absolutely. No, absolutely.
By using AI, we will increase the throughput or your turnaround time. No, that the radiologist and the clinicians decide whether it is going to be useful here or there. It cannot be dictated by industry. So when the industry makes a statement, we need to have authenticated clinical experiential.
That's an amazing point.
Evidence. Well, and the last point, of course, is regulatory. There is a second part of regulatory is there's a law, there's a legal part. If a report goes signed to the patient, for example, this is a computer-generated report, a signature is not mandatory, blah, 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 blah. Does that absolve you from any legal or any liability? No, it doesn't. So we have to be very clear about that. Who is going to take the liability ownership of a report which could be, which could have a age wrong, it could have a sex wrong.
But today I think the accountability is with the radiologist.
Why the radiologist? The radiologist says, I never gave consent to use AI.
Of course.
It was pushed on me.
In the institutional framework, yes.
You need everyone to basically.
Absolutely.
So when you say the simplest thing of triaging normal chest X-ray from abnormal chest X-ray, it could also make an error there.
Yes, of course.
And if I'm spending time on a chest X-ray looking at it for maybe a minute to decide normal, abnormal, and I start trusting my engine and my algorithm, and I also may tend to get biased by my own engine.
Right.
So that's where I'm saying we need to be very robust on it. And the model of the X-ray which you have trained could be coming from a country which does not have tuberculosis or lung cancer.
So, Nani, one of the big purposes of this podcast was, and I'm being a student of leadership, has been that I always believe that one of the things that is needed the most in healthcare is actually leadership. And many of the clinicians, and as you are a great example as well, have to take leadership roles and have to grow as a leader and wear that leadership hat. And probably we need more and not less of them, right? What would you say, and some examples in terms of lessons, in terms of how clinicians who have aspirations to be a leader of an institute or of a department, or what they should be preparing themselves for, right? And any good examples of some people that you think they've done really a good job as a leader?
So I think I've been fortunate. I worked with two great leaders, Dr. K.B. Bryant himself, great guy. I think boss was a great mentor and leader for many people in Pune. He kind of brought almost all the best of technologies. Great person. And the other leader I would say I worked with was basically Dr. Sadullah in Kim's Health. He's a great people person, always looking forward to new things and taking people along with him. But what a person needs to do to become a leader is something he needs to basically be surrounded by people with those kind of good habits. He has to work in the tribe of leaders. He has to see them closely, work with them, be their understudy, and he needs to not just look at being a Napoleon in that whole journey, but understand his ecosystem, his department, his people, his balance sheets, his profit and loss statements, his financials. It's very important that they understand communication is a very powerful tool, direct and a lot of indirect communication, and ability to take those difficult decisions. There's a book on Eat the Frog. The first thing when after reading that book I realized I used to always procrastinate on tasks which are very difficult. And I realized you change it around, then start your day with Eat the Frog decision the first day. If I have to fire somebody or penalize somebody, then do it at the start of the day so that you have the whole day to do more important things. Unlike certain HR practices which says you're fired or you're leaving on Friday and you're welcomed on Monday, and then you have a weekend to digest that good or bad news, whatever. So I think leadership in India is, we have many of them and we can see it in every facet. There are leadership who do it for changing the way they are working. They do it for their own passion to grow individually for reasons of their own business or their ambitions to grow in the community, city, or the country in various positions. But you can just be a leader to do good for the people you work with.
So, but what you're saying essentially, the skills, what I hear from you, the skills that are required as you transit to the leadership, one you're saying is the ability to make decisions. So, decision making is one area that you need to get better at. B, you're saying people management in general is extremely important and understanding people dynamics. Third, I heard from you is communication. The ability to communicate in
clear
communication.
No doubts in what you're trying to say and to whom you're trying to say, not generic.
And then fourth, you said, which is very technical ability, which is you're saying they should improve their financial acumen.
They should understand
which is very important.
The financial acumen of understanding
from a clinical
business,
perspective,
because leadership is measured by profit.
Yeah, business acumen and financial acumen.
Even though you may be in a charitable institute or you may be in an NGO, but still you are measured on how much you save or how much you make for the institute that you work. And it's all about that. You cannot be a leader splurging, right?
Yeah.
You have to be a leader with a conscious awareness of the spending.
No, fantastic. I think very specific points, very perfect. This takes us to probably the last part of our discussion is future of radiology. I can't have Nani and not get a little peek into what he thinks is the future of radiology looks like, and which are the big change areas, which are the specializations, and how do you see this whole evolving?
So that's a very loaded question. I can maybe answer maybe one or 2 points on that because I think future of radiology is the radiologist, and I was just recently in the AOCR IRI and I moved to Arab Health and I was trying to see what is new there, which excites me. And unfortunately, I didn't feel that excited throughout the whole thing. And I was following up RSNA and the blogs and the posts, and I didn't find anything really exciting. And I realized the whole excitement is not happening in the clinical realm of radiology the way it should. We're still very, very conventional in the way we approach our patient. And we talk about the way technology and industry is evolving is again putting patient first. So if you ask me, where should the future of radiology be, is that we have to defragment the whole modality business in image of CT, MR, ultrasound, vascular X-ray, and put it all in one box. It's like imaging. Basically, it should be like a Swiss knife. You cannot, I think in radiology, what is happening is there are many instances in which we are duplicating the imaging like for like. It's like your concussion substitute thing. So I think that's where we need to look at radiology, that you do one imaging test and you should get a diagnosis. So that's where the future should look at. I don't want to do ultrasound for you and then put you on IMR or a CT and then, so I don't want to do a second test. I want to do one imaging in which I find the answer. So that's where we need to move. But unfortunately, that's my wish list. I mean, I don't, if you have a headache, I'm going to give you one tablet. I'm not going to give you 2 tablets, saying that if this doesn't work, well, this will. That's fine. But at least you have one tablet for that. But in radiology, there are many conditions you will say, no, we can use it in OBGY, we do this. Yes, I know, but I still feel there's a lot of
we need to move towards
you need to do at least multiple imaging and sequential imaging, because I think there are eras of doubt in our structure of report. Radiologist future will depend on the doctor himself. Technology is there. Industry has given you the technology, but I think we have to be a little bit more sure. And I don't know how much AI is going to really push us to come to more accuracy and building that confidence level of saying this is X kind of situation.
Is there anything in particular from a technology perspective that you feel the industry should be really giving more of or less of?
I think coming closer to the patient, that's edge computing. If you can bring that, much definitely. I think that's where radiology is moving far away from
POC.
Radiologist, I think too many laws, too many regulatory constraints to bring radiology to patient. So I think point of care is something which is very exciting for me. Point of care today, if you look at many of the people are using these handheld devices which could be. So again, between radiation equipment and magnetic resonance and an ultrasound equipment, I feel today what is going to touch all patients' lives is going to be ultrasound. It's really going to come close to the patient, especially handheld devices with edge computing, with cloud and over the air kind of transmission. You should be able to do it for almost everything. And that is where I feel will be the next step, which it can go to space.
Wow. No, excellent. So some rapid fire for you, Nani. So more on a personal side, and that's where we'll end. Favorite food?
Dal chawal.
Favorite restaurant?
In Pune? Mystic Masala.
Mystic Masala. Okay. I have heard that you are a very, very good cook. What is the best dish that you make in your opinion?
Lamb chops.
Lamb chops. Okay. 2 things that very few people know about you.
That I cry sometimes.
Okay. 2 things. One is that,
and I can't give up sugar.
Okay. So can I not? Yeah. CT, MR. You kind of answered this, but still I'll ask again. CT, MR, ultrasound, X-ray. Your favorite technology?
X-ray.
X-ray. Oh, that's interesting.
Conventional X-ray is my first love.
Yeah, that's nothing like that.
Nothing.
Right.
Nothing. No challenge than trying to report X-ray chest.
Perfect. 2 most important decisions of your life.
I think the recent one, moving to Japan. Basically, that was coming at 59. And the other important decision was basically to get into business school at the age of 53.
Oh, lovely. Wonderful. We have some common denominator. Thank you so much, Nani. Thank you so much. I think it was a pleasure to talk to you.
Thank you. It was a pleasure.
Thank you so much.